Good afternoon, everyone. Thank you very much for joining us today. So we have the pleasure of having both Professor Teresa Betancourt, who is the Salem Professor in Global Practice at Boston College School of Social Work. She's also the director of the research program on children and adversity. And we have one of her collaborators, Gautam, who is the senior community advisor of the Bhutanese Society of Western Massachusetts and an FSI-R community advisor at the RCA. They're going to be talking today about family-based mental health promotion for Somali Bantu and Bhutanese refugees. The results of feasibility and acceptability trial that they did.
Thank you so much, Teresa, and thank you everyone in the program at Yale for inviting us today. It's really our honor on this very momentous day in the history of the United States to be giving this talk, especially to focus on new Americans with a refugee life experience and our work in community-based participatory research to develop an intervention and to share with you some of our early findings on feasibility, acceptability, and where we'd hope to go next. So I'm Teresa Betancourt and Bhutan.
Hi, I am Bhutan Gautam, and thank you for the introduction earlier. And I'll also let you know that I am sharing a lot of my lived refugee experiences in addition to our current research program with children and adversity with Dr. Betancourt.
Thank you, Bhutan. It's such an honor to have you here and to share this platform with you. So I'd like to just give a little more information about where I'd like to go with the presentation, some background on our research program on children and adversity and its conceptual drivers. And then Bhutan's going to talk about the principles of community-based participatory research and its use within two communities, the Somali Bantu refugee community, starting first in Chelsea, Massachusetts, and then moving out to Lewiston, Maine. And I'll cover some of that, and then particularly from his lived experience, talking about the Bhutanese refugee experience. And then we'll talk about the intervention that we co-created and our early findings on feasibility and acceptability in a recently published trial in the Journal of Adolescent Health. And then we'll talk a bit about COVID-19 and how we are iterating and adapting and using technology as the team adjusts to this global pandemic and how to still serve families in the community-based participatory research and intervention study. So as you heard in the introduction, I direct a research program on children and adversity. And in this work, our focus is to really understand factors and processes that contribute to risky life outcomes as well as resilient life outcomes amongst children, youth, families, and their broader communities that face adversity globally. And the focus in this work is not just on deficits, but on strengths and capacities. And in learning about this sort of information, we hope to contribute to developing an evidence base that's based on local strengths and resources, and also helps us close this no-do gap, that we know a lot about the science of early adversity and its impact on child development and mental health, but we still see very large treatment gaps in low resource settings, both in the United States and around the world. And we need to be doing our highest quality, most efficient and effective work in those low resource settings to address racial and ethnic disparities in health. So we have a range of research projects within our lab. They sort of fall into these three broad domains. First is the global work on war-affected children. We've had research projects underway on the Ethiopia-Eritrea border, in the Russian Federation with the Chechen displacement, on child soldiers in northern Uganda and other internally displaced persons. And then for now 18 years, we've been working in Sierra Leone, West Africa, building from an intergenerational study of war, following a cohort of 529 young people, including many former child soldiers, as they become young adults, right now with 4 waves of data collection. And this has been funded by the National Institutes of Child Health and Human Development. And we now have a 15-year follow-up of this cohort just published in JCAP. which we're very honored to have that opportunity. And then we've been working on other forms of adversity in Rwanda. We started first on the topic of HIV/AIDS affected families, and in partnership with the government, as well as the World Bank and others, USAID, have moved towards a focus not just specific to HIV, but on children in extreme poverty, and using a family-based preventative intervention that's been adapted to focus on early childhood development and violence prevention. And so we've just published the pre-post results of a trial, a cluster randomized trial of over 1,000 families in Rwanda with the intervention we call Sugira Muryango. And that actually is the same family strengthening intervention that's at the base of the intervention that Bhutan and I will talk about today in our project on promoting resilience and healthy parent-child relationships in new American families in the United States. And this work is sponsored by the National Institutes of Minority Health and Health Disparities. And we've had an R24 as well as an R01. And we're going to share with you the early results from the R24, and the R01 is underway. So Bhutan, I'll turn it over to you.
Sure, thank you, Dr. Betancourt. There is a background image. You can see that lots of the times when I talk in this kind of forums, people ask me, what does the refugee camp hut look like, the house look like? And this is what it looks like. In 2015, I went to a refugee camp in Nepal where I became refugee for 15.5 years before I came to this country. And I took this picture, which is one of my friend's house, and which is really small, and that's really ties into this largest humanitarian disaster that's happening since World War II. And again, that's going in the middle of pandemic. Look at these numbers. Globally, at the end of 2019, there were about 80 million people forcibly displaced. And if you see the number of children living in the conflict zone, which rose by 74% of the last decade. So if you think at the United States, which we will talk about, I will show you more data about how the resettlement landscape has changed. And that really needs additional interventions to address the needs of the refugee population who comes with the unique needs.
Yeah, thank you. When we talk about the unique needs of refugee children and their development, their mental health, we have to go all the way back to Yuri Bronfenbrenner and think, developmentally, ecologically. We have to think about the role of time and maturation. So certainly ontogenetic or individual factors matter: age, gender, temperament, intelligence, your genetic history. But we also have to think about what's going on at the level of the family, the nature of caregiver-child relationships, family functioning, caregiver mental health, resources in the family. And then we can't stop there. We also have to think about the nested and interrelatedness of the community ecosystem. Who else is available in the life of that young child in terms of mentors, coaches, religious figures, other supports, extended family, peer group, which becomes all the more important over the process of development. And then, as we see in our country today, all of this is very much nested within the historical, the political, the social, and the cultural context. And this also relates to beliefs about reconciliation, healing, and moving forward. So all of these come into play when we think about any one child's outcomes. Bhutan.
So if we look at the refugee resettlement trajectory as compared to last year, not last year, before the current administration, we used to have 70,000 refugees each year. That's what the US government had the highest ceiling. But after the Trump administration took office, it was drastically reduced down. And if you look at the fiscal year 2021, which is 15,000 refugees, and that's the maximum ceiling. And then when you have people in the pipeline, and then they end up coming less than the actual ceiling limit set. And today's election is going to decide what direction the refugee resettlement will take, which will we will hopefully see a change in this. But let's see, wait and see. As I was mentioning before, a person who was very young, I left country when I became a refugee when I was 7 years old, and having to spend a lot of time, my childhood and then adulthood, in a refugee camp. I was exposed to different factors that increased the risk of poor mental health and health outcomes. And I'm coming to the United States along with 100,000 other folks like me. And not only Bhutanese, but there are millions of other refugees and immigrants coming with these different forms of hardships they have with them. So the data shows that children in the US have very poor access to mental health services, and situation has increased in refugees from the data we have found.
Yeah, thank you, Bhuwan.
And also, when refugees come to this country, they have many barriers as compared to the US population. For example, refugee folks are really reluctant to seek out services because of the stigma in mental health. And also there is, because of the language barriers and cultural differences, there is lack of resources in the areas they live. And most families are overwhelmed by their own migration experiences. Similarly, services access is very poor, especially for children, and families may not be able to recognize their own needs. I mean, to be to not to have clinical access or mental health access is what they had in their camp. And when you come from a place like refugee camp, sometimes being a refugee, you don't even know what resource exists. And sometimes our parents even may not be able to recognize their own needs. And they are unaware about the services, as the refugee and immigrant folks are. They do not have a high literacy rate, and the resources are so low. And also, because of so many other barriers, they are limited to referral networks from school and pediatric, etc., to address the needs of our refugee children. So when you see at the trajectory of the stages of the displacement, when somebody becomes a refugee, and then they go through different stages of life, for example, pre-flight, someone had, for example, I can put myself into this stage that I was in Bhutan. As I mentioned, I was very young. I had to leave. I was the first grader, actually. And I was exposed to the violence, and I had many other forms of traumatic experiences. And when I came to the United States, as I mentioned, in 2008, I was, again, it was a new journey for me along with my family to go to the place that they don't even know. It's like an unknown destination. Even if they said United States, that means it was completely a foreign land. Both of my parents are illiterate in their own language, and imagine about leaving a country and going to a place that they don't actually know what's going to happen. And other resettlement also brings migration loss and acculturation issues. It's a lot when someone has to go and learn the new language and adapt to a mainstream culture, and along with the financial hardships. But also to let you know that there are protective factors that refugee families bring, which are really great in terms of building together as a resiliency factors, from individual to family, to access to education, and community ties, ideological and religious context. I mean, we refugee communities are coming from a low resource settings, and then having to go and reintegrate and then acculturate in with the mainstream society sometimes requires a lot of efforts. And I think this kind of collaboration and a partnership has really helped us to move forward. And with these positive protective factors, researchers really have to put this together to build the intervention that works for refugees.
Can I please ask a question?
Sure.
Yeah, Bhuvan, so I had the impression that Bhutan is a very peaceful country. So I am kind of completely at loss that there are refugees from Bhutan to the US. So if you could please share the perspective, like what led you to become a refugee?
I'm glad that you asked this question. Thank you so much. I know that Bhutan has been Bhutan says that it's the happiest country on the world, which you might have heard. That's one of
Yeah.
the countries gross national happiness, right?
Uh-huh.
But that's the other side of the story. Now, the truth of the matter is that Bhutan has forcibly evicted over 100,000 Nepali-speaking Southern Bhutanese from its country in early 1980s to 90s, which I was going to talk, but that's great. Then I can skip later. And I am one of those people forcibly evicted and became refugees. And if you see, that's one of the reason that we partner with Boston College and Harvard School of Public Health to basically to heal the mental health problem, the torture mental health problem that Bhutan had created, so that our families could be helped. We have lots of people who were the victims of the torture by the Bhutanese authority, Bhutanese police. We still have families separated in Bhutan who are not able to join our families. They are in jail. There is a horrible other part of the story, which I would encourage you to look into it, and you will have a deeper understanding about the plight of the Bhutanese refugees.
Okay, thank you.
And we
Sorry,
can,
can I?
yeah, sorry, go ahead.
Now I have a follow-up question about this. So I was reading a little bit about the situation in Bhutan and the kind of policies that they implement in schools. It seems that they socialize children since a very early age, and the way they communicate with the children and they convey the importance of being happy. I guess I was wondering, how does that affect your measurement of well-being, your measurement of depression, for instance, which is so susceptible to how you think about your emotional states? And do you think this poses an additional challenge for measuring depression? Do you think that biomarkers might be particularly necessary in the case of Bhutanese refugees? How do you think about this?
Well, to tell you the truth, that when I became refugee, as I mentioned, that I was very young, and I really started to understand the complexity of this issue when I became adult in a refugee camp in Nepal, and I further understood about my own rights, about not being able to practice my fundamental rights is something that I'm experiencing, and I'm really whenever I go to the platform, I talk about these issues when someone comes up who have never heard about the other side of the story. But to go with the flow of this presentation, we have a lot to cover, and Dr. Betancourt and I really initially were talking that we might have to answer some of the questions. When you have something coming up in your mind, please continue to jot down your questions, and we will have the question and answer session to go through them to cover the whole presentation.
Yeah, thanks, Juan. And I think the question on biomarkers is an important one. A little bit about some of the form of work that we did to make sure that our measures were fit to context and reflected sort of culturally appropriate language that is used by locals who may not have had the opportunity to, receive much education and may not be literate, but really doing a lot of formative work in a community-based participatory research framing to learn those terms and make sure that we weren't using stigmatizing terms. And then the collection of biological data, biomarkers as an objective indicator is also very interesting, something we can talk about, I think, in the discussion a bit more, because there are ethical issues also involved in that, trust and relationship in communities, as you know. So let me talk a little bit now about just the co-creation process of intervention development in collaboration with refugee communities using community-based participatory research. And Bhuwan, do you want to talk about some of our different partners?
Sure, I want to talk a little bit of the history of the project and acknowledge different partners involved. With Dr. Betancourt and I are having the opportunity to speak with you right now, but as you can see in the list, we have several others. For example, we have in Maine, Immigrant Refugee Services and Jewish Family Services of Western Massachusetts, and early partnership that began even before I joined Dr. Betancourt with Chelsea Collaboratives and REAC and other academic collaborators, both at Harvard and Harvard University and University of Michigan, and Boston Children's Hospital, and our funding support from National Institute of Minority Health and Health Disparity, and community consultants. We have fantastic collaborators that are really helping us to develop this whole research and intervention project. So that leads to a real nice definition from Kellogg Foundation. Community-based participatory research, CBPR, is a collaborative approach to research that equitably involves all the partners in the research process and recognizes the unique strengths that each brings. CBPR begins with a research topic of importance to the community, has the aim of combining knowledge with action and achieving social change to improve health outcome and eliminate health disparities. So again, it's the CBPR engages researchers and community members like me to equitable partnership to deconstruct the power differential, and also community members are engaged in all the processes. Let me give you some of the features of the CBPR, because this is the process of power sharing as we come up with the challenges, and to address that, we focus on the strengths to offset the weaknesses, and community members are engaged in each step of the research process. So CBPR is especially helpful when working with a stigmatized community or with this stigmatized topic, because it allows you to gain deeper insights and lead enhanced understanding that creates a deeper buy-in and motivation necessary to encounter stigma. So the advantages are to increase the knowledge and to build the bridges and enhances the research process. So it might take a lot time and resource to prepare to develop the partnership, but at the end of the day, we are thinking of building the social capital strength in those low resource setting communities. As I can emphasize that there is a limited implication so far in mental health, and this is we are so glad that we are sharing our work with you all. CBPR has promising research approach given the stigma around mental health, and it's really important to understand the local context and language around the mental health problem that can improve the community engagement and inform the intervention. So our CBPR approach is by refugees, for refugees. We have unique approach. We have two CAB community board advisory boards. One is youth CAB, we call youth CAB, and in youth CAB we have middle schoolers and high schoolers. That because the research program is for the children and the parents, we continue to seek advice from those children's point of view also, and from the parents who are the CAB members, adult CAB members, sharing their feedback to the research, which will help us to document their and which will help us to document their feedback, and we would develop culturally and linguistically appropriate intervention in our FSI module. So community outreach events we try to spread the work that we do as much as possible, not leaving anyone in the community. Also we have monthly meetings, and I am one of the liaison with the Boston School School of Social Work with Dr. Betancourt, and our job, and not only me, I have other colleagues who are not here. Our job is to advise on our cultural and social and cultural needs.
Great. So I'll give a little background on the Somali Bantu refugee community and then turn it over for Bhuwan to give a little more of the history of the Bhutanese displacement. So the Somali Bantu refugee community is actually a subset of the overall Somali displacement and resettlement around the world. The Somali Bantu peoples were originally generations ago taken from other parts of Africa and served as slaves in Somalia. When the war broke out in 1991, they were displaced along with the broader Somali majority to refugee camps originally, and then also resettled. Although the early displacement were from Somali majority families who had access to education and connections, but there was a decision of the Obama administration to take a large number of Somali Bantu as well. But their trauma history is quite high, as you might imagine. Very little access to school historically, prolonged trauma exposure, both just within their families as well as in the refugee camps, Dadaab and Kakuma refugee camps in Kenya, and have had very little access to education. So a lot of the women, the mothers we work with, may not have literacy in Mai. It's mainly a spoken language. And so English as a second language or English language learning has been very complicated. And we'll see situations where children are learning English, but especially the mothers haven't had the basics to allow them to have a platform to succeed in those sorts of training programs. We need a different type of literacy education and integrated approaches. Overall, Somalis are the largest single group of resettled African refugees in US history. And then the Somali Bantu are a subset within this. In 2004, over 13,000 Somali Bantu were resettled in 50 communities across 38 states, United States. So in Boston, resettlement began in the Boston area in 2004 with 2 families and soon expanded to over 400. And then there was secondary migration to states where jobs were more plentiful, where housing was more affordable, including to Maine and Lewiston, Maine, being a very large population of both Somali majority and Somali Bantu refugees. And there have been historical tensions, but also a lot of shared culture, history, experience between the two communities. And many of our partners are coming from both sides. You know, this project's mainly been done with the Somali Bantu because of the language and the cultural differences, but some of our greatest collaborators are also Somali majority who are trusted by the community and work very closely with them. Over to you, Bhuwan.
So I'm going to provide a background of Bhutan. Bhutan is a tiny Himalayan country sandwiched between India and China, which is really isolated kingdom of about 700,000 population. And as I was speaking before, Bhutan government evicted its citizen by adopting ethnic cleansing policy in early 90s. Evicting 100,000 ethnic Nepalis, we call Lotsampa, that we speak Nepali language in Bhutan, under one nation, one people policy, which is also known as Bhutanization, that targeted cultural and religious traditions. Majority were Hindus, but also we have Buddhists and Christians as well who were evicted. And also our parents' citizenship rights were eliminated. And we all were forced to leave to neighboring countries, and we had to cross India to get to Bhutan. And I remember following the footsteps of my parents. I was young, but then I remember sleeping on the woods. It took so many days to get there in refugee camp, Nepal. And in a refugee camp, we were settled. This is one of the pictures that I was talking about. In this kind of setting for 15 and a half years, there was no bathroom, no toilet inside. There is a lot of public health problem, which I am able to recognize that. But again, we got survived, and I'm here, and that's why it's really important to deal with the hardships and problem that refugees bring. To address in a culturally and linguistically and appropriate way. And many escaped the violence. And at the time I became refugee, when I was in high school, there was a civil war in Nepal that had affected many of children in Nepal as well. And there was really a difficulty, not even difficult, I mean more than difficulty. Refugees are not allowed to go outside their refugee camps to school. The maximum I could go in my refugee camp was 10th grade, and you're done. no education after that. Employment, forget about it. There is no employment. You have to survive your life on the basic food ration provided by UNHCR. And there was a discrimination from the local Nepalese.
Bhuvan, I have a question.
Yes.
So what was the relationship like before Nepalese Bhutanese were driven out? Like, was the relationship very complementary, or like it's just I'm still in shock that I had not expected that at all from Bhutan.
Sure. I mean, the Bhutan, it is a monarchical system of government. There is a king and prime minister, and Bhutan had no problem before 1980s. But after that, when the Bhutanese people, Nepali-speaking people, became educated and they started demanding about the fundamental rights, and it became a problem. The community became target, and also the other socio-political influences. Nepal was going through political reforms, as well as in India, and all kind of neighboring influences, geopolitical issues might have.
Okay. Thank you.
And Bhuvan's written some very important commentaries we can share with the group when there have been these events in New England around, Bhutan, the happiest kingdom on earth, and not recognizing this truth of their history. It's much more complex than that.
Yeah.
Sure. So there is increased mental health problems when refugees they come to this country due to the resettlement stressors, including cultural adaptation, language, and overwhelming information. Anxiety, which is likely to remain for a prolonged period of time, and the fear for future resettlement in crime-affected areas. And also refugees need to compete in the job market all of a sudden after 20 years of jobless life, which is not easy. And as you see in Bhutanese refugees context in the US, third country resettlement began in 2007, and I was the first persons to come in Springfield, Massachusetts. Before that, I had no idea about what Massachusetts was. In fact, I was told you are going to Windsor Locks. What is Windsor Locks? I didn't even have an internet to look up Windsor Locks. And in fact, I found that it was the place where the airport, Bradley International Airport, was. So and after people think that when refugees are brought to America, the problem is solved. No, there is a lot of complexities. And after Bhutanese refugees came to the US, CDC published a report that the suicide rate among the Bhutanese refugees was almost 3 times more than the national average.
Twice. Yeah, 2 times as high. Yeah.
Yeah,
a very alarming rate of suicide around the United States.
Yes.
So thank you, Bhuvan. Very important history, and also justifies why mental health was of interest when we invited the Bhutanese to join our partnership. And the partnership had started back in 2004, first with the Somali Bantu in the Boston area. And so at that time, I was working at Boston Medical Center with Heidi Ellis and others at the Refugee Center for Trauma and Resilience. And we had been contacted by the Lynn Public Schools in Massachusetts because we'd had a large influx of Somali Bantu children into their classrooms. And there were behavioral problems arising, especially in the younger grades, when teachers would ask things like, time to line up, and the Somali Bantu kids come pushing and shoving to the front of the line. And the teachers felt, that this was bad behavior. But these were kids who, back in the refugee camps, those had been really important survival behaviors. If food was being distributed, you did need to push to the front of the line. And so there was just a misunderstanding between the two contexts. The teachers weren't understanding the children and the families, and the parents themselves didn't really understand how to navigate the schools. So in Somalia, it's respectful to turn your child over to the mentorship of the teacher and to not get in the teacher's hair. So they weren't, coming to parent-teacher meetings or coming to the school and getting to know the school community. And the school saw that as them being disengaged, but really they were trying to be respectful. So there was a big disconnect happening. And we were asked to come in and do some awareness raising, which we did with the administration and the teachers and also the community. And at that time, I met Awais Hussein, who was serving as a school liaison. He himself is Somali Bantu. He's now gone on to finish his nursing degree, and he's an amazing person. And he helped us kick off this project. We wrote some early planning grants together, and building this community partnership, as you can see, has taken time to get to this place of having NIH funding. But it started with this collaboration to meet both community and research goals, because we were interested in risk and resilience and war affected children, including those who come and resettle in the United States with their families. So here's a picture of Awais. You see him down on the second row in the middle at the Chelsea Collab. And the Chelsea Collaborative is an amazing place. Chelsea is a city across the river from Boston. It's a largely migrant, very diverse community. It's been hard hit by COVID-19. Actually, a lot of frontline workers, a lot of people living in crowded housing with food insecurity. And this wonderful group, the Chelsea Collaborative, was mentoring the Somali Bantu Community Association to become their own mutual assistance organization, and to learn leadership skills, how to write grants, how to plan, which was really fabulous. We'd go in and we'd speak Spanish first, and then we'd be switching to Mai. And that's really how this project started, with that leadership training of the Shanbara Association and the partnership with Awais Hussein. And so the early aim of the partnership was to try to understand the community situation and its priorities, especially related to these issues of emotional behavioral health and well-being of children, and bringing up their human capital and ensuring that they could thrive. So understanding the nature of the problems and its causes, as well as what are the strengths we can leverage before we ever move to solutions. And this meant we had to improve communication, because there's such issues around stigma. And so if we want to talk about mental health, how do we start? So we started using methods we had used in sub-Saharan Africa and northern Uganda and Rwanda, using first free listing, and then moving to key informant interviews and getting local syndrome term cover terms that were non-stigmatizing for a range of different expressions of emotional and behavioral problems in children, and then using this information to assist in planning intervention models, because we could talk about strengths. Bhuvan, do you want to talk about our partnerships?
Sure. As I mentioned before, that we have multi-sectoral and multidisciplinary team members involved in this project. That includes academic partners, refugee community, resettlement agencies, which will guide the study intervention investigators in creating the shared vision through this collaborative research. So our CBPR team and the community stakeholders really foster cross-cultural collaboration in order to drive research questions, which will help us in the delivery of the improved services.
Thank you.
So our partnership, we have values, and our values are really invested in the refugee communities. This fits in saying that give man a fish, he will eat for a day. Teach him how to fish, he will eat for his life, right? By training the refugee folks, what you will be able to prepare them for employment in an effort to skill building in a low resources communities, like one of them is Bhutanese refugee community. And after the research project is over, the refugee communities will have produced the experts who will influence and inspire others to go for public health schools, and also address some of the health and public health problems that we had never known before. I came to this country in 2008 and worked at the resettlement agencies for 5.5 years. Till then, I had no idea about public health issues. Before I got involved with the research institutions and community health center, it's a lot when a refugee community member is involved and trained in this type of work. So in a collectivist society like Bhutanese community, these skills will build social capital resources, which can be used by not just the Springfield Bhutanese communities, but the Bhutanese diaspora.
And so now I'm going to talk a little bit about mixed methods and how we approach this work. So this quote from Arthur Kleinman, who's a very well-known medical anthropologist and psychiatrist at Harvard, captures what we're up against when we think about culture. And there was an earlier question about assessment, as well as then, what you learn locally to think about intervention development. So as Kleinman states, we know from ethnography convincingly that concepts of emotions, the self and the body, and general illness categories differ so significantly in different cultures that it can be said that each culture's beliefs about normal and abnormal behavior are actually quite distinctive. So that's where we run into problems if we just assume that tools we use with, Americans or in Western populations can just be given a forward translation and now they're going to work with Bhutanese refugees or Somali Bantu refugees. So we really try to go about this approach in a very different way, starting with the EMIC perspective locally in qualitative, formative work to understand local constructs related to mental health, to parent-child relationships and parenting, to protective processes that are relevant to better outcomes for children and families that face challenges. And then to use that data to select our measures, adapt standard measures, or where there isn't a good alignment, create new measures and test them through validity studies. And we also now we're learning not just about the problems, but about the protective resources, so the ingredients for potential intervention models that can help promote better outcomes. And so that's coming into this phase where we're informing the intervention model, selecting the intervention model based on that formative work, thinking about fit to context, and evaluate these interventions using the most rigorous designs possible, including randomized controlled trials. And now in a lot of our work in different parts of sub-Saharan Africa, and even now the second stage R01 of this project, looking at implementation science questions. So hybrid designs where we're looking at effectiveness, but also testing strategies for quality improvement, fidelity monitoring, and scaling out. So we talked a little bit about some of the formative work. If you're interested, there's a really tremendous amount of detail in this paper we published back in 2015 in the American Journal of Public Health. And this represented our community-based participatory research in the two communities and how we got at those local terms. We're talking in a non-stigmatizing way about mental health. And based on that, we also did work on the protective resources. And this work got some really wonderful attention. We made the cover of the Harvard magazine back when I was at Harvard for many years, before Salem professorship at Boston College. And also we were able to have our refugee team come and help us disseminate the results, the early formative work and what we were learning about youth issues at Chelsea City Hall with policy makers and leaders there in the community. And so now I want to talk about moving from that data to intervention, co-creation, and co-development, and talk about the family strengthening intervention. Some of you may know the work of Dr. William Beardsley, who his original intervention was developed for the prevention of depression and the offspring of depressed caregivers. After the formative work and after looking at different intervention models that could be done by lay people that were strengths-based, that really had a focus on families and their functioning as a way of promoting well-being in the children, we saw a tremendous alignment and opportunity with Bill's model. We had been working with Bill in Rwanda on adapting this for HIV-affected families, and then we had this aha moment of, goodness, this is working in sub-Saharan Africa. We're working with Somali Bantu refugees back in the Boston area. Maybe this could also work well with the diaspora resettling new Americans and the refugees back in New England. And so that was the initial idea. And we saw this as an exciting opportunity to think about making it a fit to this setting in the context of refugee families resettled in the United States. So the conceptual model, and what I also want to mention when it comes to implementation science is that Bill's Family Talk intervention is registered in the National Registry of Effective Programs and Practices. So it has a pretty broad evidence base. And in Rwanda, we adapted it more broadly, not just to depression, but to other mental health problems in children. And that was sort of the idea here too, because distress in refugee children doesn't only present in the form of depression, although, it can also show up in conduct problems, anxiety. So we wanted to think broadly about mental health and promoting mental health. And so the conceptual model here is we're working with refugee families that have this history of past trauma, as well as the resettlement and acculturative stressors that you heard about from Bhutan. Some of the risk factors that we learn about in our formative work were just limited access to services, not even, knowing much about mental health or understanding how to navigate and get help for the family, get help for children. Lots of misunderstandings, as you heard, about the U.S. education system, also social services. We can tell you all sorts of stories about misunderstanding about child protective services or 911 and all those interactions, and a lot of fear. And then just communication breakdowns, as I mentioned. Oftentimes you'll have children who are quickly learning English, because they're growing up in US culture. And then you've got a mother and parents who are coming from a very different background and may not even have the ability to speak in the same language in the same household. And so, of course, as you might imagine, we have issues of intergenerational conflict, where there's a lot of tension and poor communication between children and their caregivers. And so the core intervention components, building out on Bill's model, were first this navigation role, because this is done by refugees for refugees, with home visitors being from the community. They can help them navigate both the formal systems, like understanding the educational system, child protective services, medical care, insurance, but also informal supports, like getting additional supports from friends, from neighbors, from community associations. And as you heard in the protective processes Bhuwan discussed, those mutual assistance organizations are so critical, and the community trust and community leaders like Bhuwan are so critical. And then a lot of work on just understanding the US education system, and we've been focused really on school-aged children in this phase of the intervention, although we do want to eventually work towards early childhood development as a target. And a lovely part of Bill's model, which has a nice fit for trauma-affected populations, is the family narrative. And this is a chance for the family to tell the story of their experience as a family at their own pace with their own content. And it's not meant to focus on retelling past traumatic events, but really to focus on the strengths along the way, in the joys as well as the difficult events. What helped you make it through that time? And then where did you come from? What have you been through? And where are you going? A look towards the future and a hope for the future, which is so critical to help refugee families thrive. And then also just developing positive parenting skills, thinking about routines, thinking about improving communication, thinking about natural consequences, spending time together that's productive and positive. Those are all a part of additional supports that parents are getting, and with the intention being to improve the parent-child relationship, but also diminish risk of mental health problems in children, which we know are elevated in refugee children. So as you've heard, it's a strengths-based model. It was meant to be brief. Can be done by lay workers. It's prevention. We're not doing in-depth treatment. And the idea here is to recognize and build on existing family strengths to enhance resilience, and to use those protective resources as the active ingredients in promoting mental health in children. And so it follows a manualized protocol. We have weekly meetings between the family and the home visitor who's from the community, speaks their language, knows their culture. And we have separate sessions for children and adults. The early sessions are really at understanding that particular family and its unique challenges and strengths, and then telling that family narrative from the perspective of the caregivers, but also then from the perspective of the children, and then moving through the different skills and bringing it all together with a family meeting, which is also a very critical component of Bill's intervention. And these family meetings are something that families may go on to do after the brief preventative intervention. So we're going to share with you some initial results from the NIMHD funded R24, which was a pilot grant, to really look at feasibility, acceptability. It's underpowered to get huge statistical results. We're in that trial now. But the intention was to enroll 80 families, 40 from each community, have pre and post assessment, and have a randomization where there are good usual care services in these communities. And so just like a lottery, some families, in addition to usual care, would get the home visitor. And then all along the way, you heard from Bhuwan about the importance of our community advisory boards. So whenever we had hit snags or needed input, especially in the intervention development, but also as we went, giving updates and getting feedback from the community advisory boards in a CBPR manner, and documenting that in a process evaluation as we go. And this is all guided by an implementation science framework that we call EPIS, that really looks at these different phases of exploration, preparation for the intervention, actual studying of the implementation, and then questions towards sustainment. and thinking about these bridging factors between the community, between the actual features, the inner context of the intervention, how hard it is to do, the materials we use, making it more easy to use, and then the outer context, the funding, the policy context, and all of that's ever changing. So in the data I'll show you today, the main research questions were understanding one, I'm going to show you the qual data and then a little bit of the quant data. And we also are working on a mixed methods paper now where we synthesize those. But the questions were how acceptable and feasible is the family strengthening intervention for refugee families, or FSI-R, and what contributes to that? What kind of changes, if any, do caregivers and children observe in themselves and their families from the intervention participation, and what perspectives do they have for improving this intervention? And so I'll show you data that comes from 36 exit interviews with caregivers and with children that looked at those research questions. These were double coded and analyzed using both grounded theory techniques, but also thematic content analysis, because we have some theory driven codes. And so our sample is half and half Somali Bantu and Bhutanese, 10 families from the Somali Bantu side, 11 Bhutanese families. And the main themes when it comes to acceptability and feasibility of doing this intervention were really about, as you might imagine, just scheduling as a barrier and overcoming that, but also experiences with discussing the past, and I mentioned that in the conceptual model, and the relationship with the interventionist. And so, as you might imagine, these are families that are working many jobs. Oftentimes they're large families. Scheduling issues could be a barrier. But home visiting really helps us get far with that. When there was once a center-based attempt at this intervention that really failed because of low participation rates. And the participants shared that intervention as problem solving them was such an important part of making it feasible. So as this mother explains, they would call me beforehand, make sure I was available, and I'd tell them to come over if I was home. And we have to do a lot of double and triple checking. The Somali Bantu mother talks about the patience of the interventionist, how sometimes they'd argue and he would tolerate them, and also was very flexible about having to reschedule. The Bhutanese father here found it was easy and flexible. Experiences discussing the past, as I mentioned, is a trauma-informed intervention. This family narrative meant that this was an opportunity for individuals to learn about the family history, and even for children for the first time to hear about the history of their family and how they come to the United States. But sometimes for parents who'd been through difficult trauma in the past, just going back to any memory of the past could be triggering or difficult. And so we have to do a lot of training with our interventionists to, focusing on the strengths, focusing on the journey forward, and that they're here today and they're safe, and what's the future that they look for together. And so here's a Somali girl saying, my favorite part was when we talked about my grandparents and stuff. My mom never talked about them before, and I liked knowing about them. Or the Somali mother. Most of the intervention was fine, but the only thing I'd say I didn't feel comfortable was talking about what happened in the past in Somalia and in the refugee camp. Life wasn't easy for me and my family. Here's a Bhutanese boy who said, the interventionist asked us about family, what happened in the past. All of that I felt good about. He asked about my birthplace and everything after that. I had forgotten a lot of things. I got to know things I didn't know because of him. And so when it comes to the relationship with the interventionist, participants spoke very highly of having someone from the community, describing them as respectful, patient, understanding, and seeing them as a real source of knowledge. And so the fact that they were part of the community really contributed to the acceptability of the intervention. So here's a Somali Bantu mother. I think the interventionist did a good job. I can't see how anyone else in the community who'd be able to do that. It was very helpful to see someone from the community working in the project, and we understand each other. Here's a Somali Bantu mother. Also, the interventionist is someone who understands the dynamic and the function of the intervention and the Somali Bantu culture. So when talking about the impact on participants, primary themes that emerge relate to improving communication, more positive time spent together as a family, and also the relationship between caregivers, as well as the relationship between children and caregivers. And so for family communication, we see that, especially for Bhutanese families, they talked about how the intervention led children to share more with their parents and vice versa. Parents took more initiative to talk with their children about their lives. And for many Somali Bantu participants, they talked about the increased time together, discussion time as a family, but language barriers still continue to hinder family communication. So here's a Bhutanese mother. I learned that we should not avoid children. We used to do things in certain ways because we didn't understand, but now we understand that we should talk to each other and ask about how the other person is doing, who he's with, where he's going. When I said he could talk about these things with his mother. We still share things between mother and son. Now we know things happening in each other's lives. Or here's a Somali Bantu girl. Just to talk with my family was the best. I never talk with my parents like that. And sometimes culturally, and especially we see this in sub-Saharan Africa, it's not typical that you would speak directly to your parents about your life. And if you had problems, you might go through an intermediary. And we still respect a lot of those approaches when we help families problem solve when they're facing challenges. But also just opening up communication channels has been a huge part of the intervention. Spending time together, they talked about enjoying time together. This Bhutanese mother, I didn't know how to give time to children at home. I liked that. We learned a lot. We got to give them time. I learned this should have been like this for generations. Or the Somali Bantu mother, another one. The intervention affected family relationships in a good way. None of my children used to talk before. Now we sometimes sit and watch TV together. I always remind them about the interventionist and what he told them. Here's a Bhutanese girl, a 12-year-old. The thing that was really helpful for our family is to go to different places to make plans. Now, this is pre-COVID, but there are still ways we're helping families think about making there be really pleasant time together shared as a family. She talked about, talking about very simple outings to a park, a theme park, a water park. They felt closer. And she said, before this, my mom and dad had a really busy schedule. They made more time for us, so we had more time to go out and be a family. Relationships between caregivers. So it's different between these two communities, but again, it's a small sample. A lot of Somali Bantu mentioned the intervention. Very few talked about it really changing the caregiver relationship. The Bhutanese stated how their relationships had been positive, but children really did observe changes between the caregivers. Here's a Somali Bantu mother. I love my husband. Was it supposed to change? Here's a Bhutanese boy who said what he observed was, well, before my dad just came back from work, slept, said nothing to my mother. Now he comes back from work and actually sits down and talks to my mother, how her day was. They talk to each other. I think they found a better relationship when they took part in the intervention. I think they understand and they like each other more. So when it comes to improving the intervention, the kind of feedback that they gave were, one, about seeking tangible skills, which you can imagine, literacy, jobs, these things still really matter. And also moving from a family focus also to think about how can there be more leverage of the strengths in the communities. So seeking tangible skills, even though the intervention was doing really exciting things on the family dynamics, they talked about so many other services they need. And you see this from a Somali Bantu mother. I think you need to start services for the people like English classes, parenting classes, youth group for both boys and girls, parent groups, money saving programs. Here's a Bhutanese father talking about disability, which was pretty high within the Bhutanese community and remains to be a dynamic of the resettled populations we're working with. And also alcohol abuse being another important topic. Whether connecting them to the services or some financial assistance or education and transporting them, those are all things that Bhutanese parents were feeling they still needed attention to. Here's a Bhutanese boy. My mom and dad can't speak English. If they need to go to the hospital, you need to be able to speak English. So to help our parents with their English, that would help us a lot. And then we saw this dynamic, especially coming from the youth, to talk about how can we also do things at the community level. So here's a Bhutanese girl. If there was a hall for children to come together to play, dance, talk, learn Nepali language and culture, we can't afford that for our kids or this young boy. Services like youth groups or women's groups or men's groups or couples groups to bring the community together at least once a month or twice would be great. And that's why our community meetings are oftentimes an event with food. We've had cultural events together, and that's why working with community leaders like Buwan is so important for hearing this kind of feedback and for them to think about what they can do with those requests from the community. When it comes to the quantitative results, and these are just published in the Journal of Adolescent Health if you're interested, with this pre to post data collection, we did see in the children a significant reduction in those getting the intervention in their reports of traumatic stress reactions. We also saw from caregiver reports fewer child depression symptoms reported by caregivers for both communities. And then conduct problems kind of went both ways. For the Bhutanese, we saw a significant reduction in this small sample in conduct problems, but for the Somali Bantu, we actually saw that it looked higher in the intervention group. So some of that could be due to variability in small samples, but definitely the general trend is there are exciting shifts in child mental health in this small sample. We also saw in the Bhutanese side of the equation a report in reductions in family arguing. And when it came to feasibility and acceptability for both communities, extremely high reports of feasibility and also high reports of satisfaction and acceptability. And so future steps And I want to make sure that we have a little time to talk about COVID. As you might imagine, and as Bhuwan mentioned at our introduction, the policy and the political landscape are ever shifting. If you can imagine what this project has seen in the years it started from 2004, 2005 to 2020, a lot of shifts in policy, funding, resettlement dynamics. When we originally developed this, being done by community lay workers or community health worker provisions within the Affordable Care Act, and also provisions for prevention services, were really a big part of our vision for how we might have this scalable and reimbursable, should it be evidence-based, should it continue to show an evidence base. And that's meant we had to really focus on state level policies in Massachusetts and Maine around prevention services and what's reimbursable and who the delivery agents can be, including lay workers. And we need more on, is it truly effective? And that's why we're finishing now a well-powered effectiveness study, as well as the process evaluation steps we've talked about. So Bhuwan, I'll turn it back to you to talk about COVID-19.
Teresa, can I ask a couple of questions, or should we wait to the end?
You can ask them now. Is that Horacio?
Yeah, that's me.
Great.
But I'm happy either way. If you want to, Bhuwan.
Well, we're almost done. Let us finish these last slides, and then we'll just open it up.
Okay.
Sure.
Yeah.
Thank you. Due to the COVID, it's really challenging. Before COVID, we used to collect our data in person. Now with the COVID, we are collecting data remotely. And our bilingual, bicultural Nepali speaking trained family strengthening intervention staff, they are the ones who do the data collection. Besides the intervention work, at the request of the communities, we have supported in providing vitally important public health information, especially around debunking some of the myths like eating ginger, garlic, or steam Vicks would ward off the virus. We were able to bring epidemiologists and researchers and conducted those information session and outreach and provided education via Facebook Live with live interpretations for our Bhutanese population. And our upcoming one is about supporting the students and families in the Bhutanese community with remote learning during this COVID-19. Parents are frustrated, children are everywhere. It's a mess when, especially in our community where parents don't know what's happening. And with that, I would like to turn it over to Dr. Betancourt to talk about digital manual. And
sure. Thanks, Bhuwan. And just on the Somali Bantu side, it's interesting, just there are user preferences and differences. So Facebook Live makes sense for the Bhutanese, but for the Somali Bantu, they don't use Facebook Live. And so to reach those communities, we're working with the local community leaders using WhatsApp groups. They do a lot of psychoeducation out of their center where they're still in a socially distant way, wearing masks, holding some sessions on education for families. So it's all about working with the community and understanding their dynamics, their needs, their preferences. And related to this, as you can imagine, trying to do the intervention solely over the phone, now that it's impossible to do face-to-face data collection, has been really challenging. What's really exciting is we had, prior to COVID, launched this partnership with Boston College Computer Science Department and Sunan Bhattacharya, the Vice Provost for Design and Innovation, with a small internal Boston College grant to develop a technology platform where we could swap in the language, the graphics, to quickly adapt the manual for different refugee groups. And this was a part of our scaling strategy. And so with COVID-19, new energy really came into that process of thinking, how can we use digital supports for the community health worker to do the sessions in a way that's engaging? And now we've really started to focus on the family-facing version of the app, which would be done with the family together using a tablet at their household rather than people on Zoom, which we're still able to do sometimes by phone, sometimes by Zoom, but to make it more engaging because they're getting interrupted. There's lots of kids, to use video, to use imagery. Has been a really important part of this next phase, using human-centered design and co-design techniques. And the idea is if we create using a platform that could work on a smartphone or a tablet, now we have a flexible platform as you think about the ever-changing migration and refugee patterns in higher income countries, where we can adapt these interventions quickly with new imagery, with community-based processes to think about what's appropriate in the intervention content and have different versions of it done by lay workers that could be readily scalable. And so that use of technology has been really exciting. And right now we've got a Somali Bantu version and a Bhutanese version, but you could see in the future how we could have Afghani, Congolese, Venezuelan. So that's a really exciting new development using technology. So just to wrap up, so I can open it up to questions. I hope we've been able to convince you that promoting mental health is about also looking to the health of the family, and it's critical to longer term success of new Americans and investing in their human capital. That to do this is really going to take partnerships and changing the narrative to more of a strengths-based approach about new Americans and refugees. And community-based participatory research is a promising approach for engaging communities. It's iterative, there's continuous integration of lessons learned, but it also helps us to attend to the concerns of the community, as well as do very fruitful, interesting research together. And ultimately to arrive at interventions that are acceptable, sustainable, feasible, and hopefully able to be scaled. So with that, I'll wrap up our formal presentation and we can open it up to questions. I did want to mention that we are hiring. So those of you interested in this kind of global work, both in the United States as well in sub-Saharan Africa, here's the context. Please be in touch with us. We're doing this kind of work in so many different settings, and we're just really proud of this research with our Bhutanese and Somali Bantu partners. A lot of references to our presentation if you're interested as well. So there you have it. Now we can open it up.
All right. That's super interesting. Thanks very much, Teresa and Bhuwan. The questions I have is that I would be very curious to see the quantitative results, especially of the new study, and to quantify the in a rigorous fashion the impact of on a certain outcomes. But I would be also, I'm convinced that the emphasis on both the family and the community. I was very impressed by what you've been saying about the community meetings and trying to involve in some fashion the whole community. I find that very interesting. And I would like to see, if possible, at some point, both the impacts on those mechanisms. So what is the impact of your intervention on the community itself, on how much people trust each other, how much they collaborate? And there are a number of quantitative measures that one can implement and collect to do that. In addition to that, I would also like to understand the extent to which this community effects and these family effects act as mediators for the final outcome, from the final mental outcome. And finally, in terms of implementation, would love to see, I don't know whether there is power enough in the experiments that you're running, but something that would be very interesting would be to, especially with COVID, especially with thinking of how to run interventions with a limited amount of resources, it would be really interesting to think of what aspect of the interventions are crucial, are key to obtain certain effects. And therefore, but in order to do that, you would have to have a variability within the treatment groups in those aspects. And sometimes, you can make a virtue of some problems. So suppose they have some locations where the people running are higher quality, whatever, or you can randomly variate some aspects of the interventions. And I'll stop here.
Yeah, no, these are all really important methodological issues, and it's exactly why Bhuwan's now applying to PhD programs to help contribute to all the richness that is still to be done. Just to give some brief answers on the methods, and then Bhuwan should talk about the lived experience of the community, because he's certainly more expert than I am. But I absolutely agree with you that there are designs and measures that we can do at the community level. In my public health training at the Harvard School of Public Health, I worked with Tony Earls on his project on human development in Chicago neighborhoods, which is famous for its paper in Science on the measurement of collective efficacy, which is a synthesis of informal social control and social cohesion. And they had an independent neighborhood assessment of that. So it wasn't just self-reported by people in the intervention, but you could go door to door and get a measure of it by neighborhood. And wouldn't that be amazing? Should we be able to scale this to collect that kind of community data with these kind of processes, some communities randomly being allocated to be in this kind of CBPR work and others to be usual care control sites? That would be fascinating. And then when it comes to the community effects and family effects acting as mediators, absolutely. And that's sort of in our conceptual model, right? That we really see if we can shift the family dynamics, and that also means their navigation of community relationships and resources, we believe by theory that we can improve the mental health of the kids and see better family functioning. And, you know, in the 80 family pilot, there's not much we can do. In the 150 family data, once we get that complete, and we're about halfway there, maybe getting beyond halfway there now, but COVID has slowed us down, we'll have a little more statistical power to do those sorts of mediational analyses. And then lastly, when it comes to thinking about dismantling studies or isolating the active ingredients, this is certainly a topic of great interest in evidence-based behavioral interventions of many sorts, mental health, early childhood development. How do we make sure we're doing the most powerful things and like removing the noise? And then also thinking about what works for whom under what circumstances. So what modules, given a family's makeup, really need to happen with this family. And we do a lot of this. We have supplemental modules that we may swap in and additional referrals that we often are making along the process with the family, and substance abuse being a common theme that we've had to do a lot of referrals, or treatment for post-traumatic stress disorder, depression in the caregivers, or housing insecurity, food insecurity, legal issues. And so it would be very interesting to iterate those ingredients and use dismantling studies. On implementation science, we do have very interesting data that you may be interested in, Orazio, on fidelity. And so our implementation science strategy that we're testing builds off of some of the work we were doing in Sierra Leone, actually using collaborative teams, interagency collaborative teams, to enhance the fidelity of the intervention done by the home visitors. Now we have a small, because we have two communities, our seed team of experts are people who've done the intervention before, and they know it very well. They've been through it with many families, and they then serve as an expert guide, knowing the culture and the language, to listen with permission. We get permission to audio tape their sessions, and we have the home visitor ask permission of the family, saying, I'm learning to do this. Do I have your permission to audio tape, so that an expert in the intervention can hear how I'm doing and give me feedback so I can do my best practice with you? And, you know, oftentimes families are very open to that. You know, the recorder becomes a non-issue when you're really focused on the work with the family. And then they're doing targeted supervision. So they may come back and say, look, you're doing a great job on this and that, but here's some areas I want to focus with you to prepare for your next session. And using that collaborative team approach, we have a seed team of experts, and we're really looking at fidelity. And we actually have them score a checklist, a fidelity checklist, both about the session specific elements and the cross-cutting just performance on rapport, on relationship, on quality that we have data on. So I'm watching the time. I know we don't have a lot of time, Teresa, and I want Bhuwan to be able to speak about just the impact on the community.
Sure. Thank you for the question. And I know it's we have that's what we have talked in our values about the CBPR approach. And I mean, it takes a lot of preparation and time to invest in a community which has a low literacy rate. But again, I can give my own example that I had no prior idea about how to even to assess the needs of our population, of our own community. I mean, engaging people like me, and additionally other non-skilled people to be community health workers, and then maybe that kind of resources, if we are able to develop in the community. And also, just to let you know that our community is really a stratified society. We have lots of caste, classes, and all kind of stratification, and make sure to engage them and with the different kinds of background and those. So we'll be able to take their viewpoints. And also just to talk about the developing, building the trust, which is not easy thing to do, because refugee communities back in refugee camp have been not treated fairly, because of the politicians and all kind of bad experiences they might have had. And unknown person coming from the university, and majority of them are white, and they are coming and asking about all kind of questions about their life, background, history, given the political public charges and all kind of big things are coming. It's really scary. That is the reason we need to have real we need to find out and reach out to the community self-help organizations, faith-based organizations, to make sure that you work with the community members who are well-known in their community, so that they can bring the additional group of people, and then we will be able to do the research work, because it's really impossible for researchers alone to build up the strength-based interventions. And I think in terms of COVID, COVID has definitely brought challenges. And I think we really have an opportunity to train our community members how to utilize, first of all, to train them to be a community health workers, to do data collection and research, minimum level of training, so that they can have the skill for their life. But in terms of the sustainability, I would like to mention that after the research project is done, it's again, Dr. Betancourt has mentioned that we hope that the community health worker services would be billable in the future, and the state of Massachusetts is really at the forefront of the community health worker work. But again, this is really, we are hopeful that we will one day be able to utilize the CSW services, not only in the clinical setting, but also in this kind of research settings.
So we have run out of time. I'm sure that both Teresa and Wuhan, if you have some more questions, happy to pass along those. And if you just join me in thanking them for this great presentation.
Thank you, Wuhan. Thank you, Teresa.
Thank you so much for having us. It was a great honor on a historic day. Thank you, everyone. Stay safe, stay healthy.
You will.
Thank you.